Hey everybody, welcome back to Pharmacology. Today we'll go through the pharmacology of angina and growth. The definition of angina is chest pain due to a lack of oxygen. And the causes could be atherosclerosis, hypertension, myocardial infarctions, etc., etc. And the acute coronary syndrome is when the ST segment is elevated during the myocardial infarction, and non-ST segment elevation. So this is more like post-myocardial infarction. So the stable angina is going to be your classical, and it's caused by atherosclerosis. It's effort-induced, so it's precipitated by exertion, along with any kind of stressor, so emotions, temperature, and you give the person a nitro. Prince metal is also the variant or vasospastic angina at rest. It's caused by atheroma and vasospasms of the coronary blood vessels. So this is unpredictable. It can occur during sleep too. And one of the diagnostic criterion is the non-ST segment elevation myocardial infarction. It's also relieved by nitroglycerine. But this is only the reliever. You really treat it with a beta blocker. So an unstable or crescendo angina is caused by a ruptured atherosclerotic plaque, and it's the most dangerous because it can lead to strokes or a heart attack. In this case, this is the only one where the pain is not relieved by nitroglycerin. The pain increases over a period of time, and there is no increase in the biomarker. So that means that there is still reversible tissue injury. However, after 45 minutes, really, it starts veering into the irreversible territory, especially when you start to see certain biomarkers such as troponin in the blood. So nitrates are going to be your short-acting and long-acting drugs. Beta blockers, calcium channel blockers, and sodium channel blockers are going to be used to treat, along with the fatty acid oxidation inhibitor, Ranolazine. Okay, so first you give nitroglycerin under the tongue, or isosorbide dinitrate. This is more like in the hospital setting, but in daily life, you give a nitro, and then you give low dose aspirin and other antiplatelet drug, hypolipidemic drug for prophylaxis. So nitrates are made to vasodilate the vessels by increasing cGMP to dephosphorylate the myosin lyase chain. With that dephosphorylation, there is relaxation of the smooth muscle. So these mainly work on the veins, and it can be given transdermal. So transdermal patches are pretty good because there is a longer period of release. So these can act longer. The venodilation decreases the preload, and it decreases the cardiac output along with the oxygen demand. And so nitric oxide needs L-arginine in order to mate in vivo. So in some patients, we do give L-arginine as a supplement. Sildenafil inhibits PDE to sustain the amount of cGMP, especially in the smooth muscles of the genitalia, especially in men. So sildenafil is going to be used for erectile dysfunction, and since this also works as a vasodilators, these two you can't combine. It will lead to dangerous hypotension. The adverse drug reaction, as you can see, is the most dangerous one is the methemoglobin. The problem with methemoglobin is that it is an oxygen trap. There is cyanosis involved, and in order to reverse this, you give the patient methylene blue in order to oxidize the ferric back into the ferrous ion. But more importantly, it oxidizes methemoglobin back into hemoglobin. Other adverse drug reactions are headaches, flushing, sweating, palpitation, postural hypotension, and syncope due to the hypotension. You can't give this to patients with anemia, patients with increased intracranial pressure, thanks to the headache, and patients already suffering from hypotension. So tolerance can occur. That's why in these patients, you have to give them medication like every other day. So you need at least 8 hours between the dosage in order to kind of decrease the chances of tolerance. It interacts with other vasodilators such as sildenafil and tanadanafil. So, Monday disease is caused by a chronic exposure to organic nitrates. It's headache, dizziness, tachycardia on return after the weekend. So it can cause ischemia in the long term. These are going to be prevalent in farmers, people working in explosive industry, so fireworks, factories too. Anybody who really works with producing a large amount of fertilizer. So here we go with the nitrates, increases the oxygen supply by dilating the epicardial coronary arteries, decreases preload, decreases the myocardial demand because you're helping the dilation. So in high doses, it decreases the afterload and also decreases the myocardial oxygen demand in the resistance vessels. Okay, so nitro works within 2 minutes. It's pretty volatile, so it has to be given IV for unstable angina, coronary vasospasms, left ventricular failure with myocardial infarctions, hypertensive emergencies, and cardiac surgery. So in hypertensive emergency, it's to initially start with the vasodilation, but then you have to give sodium nitroprusside in order to really treat the hypertensive crisis. So nitro is usually used to treat angina pectoris, esophageal spasms, biliary colic, after heart surgery to relieve the pain, sometimes congestive heart failure, but this isn't really a treatment. Like I said, it's more to treat the symptoms versus the actual disease. Okay, so the problem with too much nitrate is the danger of cyanide poisoning because of the methemoglobin, right? So in order to counteract the toxicity, you want to give amyl nitrate, and then you give sodium nitrite IV in order to make the cyanomethemoglobin. And then you give sodium thiosulfate, also IV, to make the methemoglobin and sodium thiocyanate. So, and then from there, the body is able to excrete. So first, you give the amyl nitrate inhaled, then you give the sodium nitrite, and then you give the sodium thiosulfate. But that's like an older method. This is more academic because nowadays we have hydroxycobalamin, which is so much faster. So you give a hydroxycobalamin in order for it to combine with the cyanide, and it makes the cyanocobalamin, which is excretable. So instead of having like a 3-step approach, this is a 1-step approach. So calcium channel blockers, remember verapamil and diltiazem. And verapamil will decrease the oxygen demand by decreasing heart rate and contractility, so decreasing the workload or work output. Dihydropyridine or nifedipine is going to increase the oxygen delivery to ischemic myocardium by vasodilating the coronary arteries. So in contraindications, you can't use these in heart failure along with the atrioventricular blocks because it's a calcium channel blocker, so it will worsen the irregularity of the action potentials. Beta blockers decrease the frequency of the anginal attack. It also decreases the nitrogen consumption and increases exercise tolerance. So this is a good drug long term. So it works to decrease the myocardial consumption or oxygen consumption, especially during exercise. So it's going to also relieve the chest pain. But some cases there could be chest pain along with myocardial infarction and sudden cardiac death. Ranolazine inhibits the late sodium channels, and it reduces the intracellular sodium and calcium overload. So by doing that, it reduces the cardiac work and the force. So it's going to reduce the contractility, and it's going to reduce the action potential. And it also inhibits the partial fatty acid oxidation in the myocardium. So you're going to decrease the amount of lactic acid produced. It's metabolized by CYP3A4 to D6 and is a substrate for the P-glycoprotein. As you can see here, in ischemia, there's too much sodium coming in, so this is going to inhibit the late sodium channels. Ischemia, here we go. All tension, calcium overload, it's all going to affect all of this. So you're going with the ranolazine, it's going to allow the sodium to be excreted and block the calcium from coming in, so reducing the overload. Okay, so you can see here, overload, calcium overload. The problem is there's going to be mechanical dysfunction along with electrical dysfunction if ranolazine isn't given. Okay, so nitrates alone will increase heart rate and increase contractility. Everything else is going to decrease. And beta blockers or calcium channels by themselves, it's going to increase the end diastolic pressure and increase the ejection time. So in both cases, everything is going to decrease except for the ejection time. Ejection time is going to be left alone. Okay, so how do we manage these myocardial infarctions, these atherosclerotic plaques? We want to prevent the ischemia by just decreasing the workload on the heart in general and increase the oxygen delivery to the damaged tissue. So to really treat them, like long term, you have to do surgery. So it's either a CABG or a PTCA procedure. And by that, we will decrease the preload, afterload, and contractility. CABG, there are coronary bypass. So you're going to harvest the vein, usually the saphenous vein in the leg, and make these overpasses. And in PTCA, you're going to use a balloon catheter. So usually you insert it in the femoral vein and then go all the way back up to the heart. Insert it into the coronary vessels, and it's just a lead, right? It's just a thin wire. Then once you get into the location that you need, you inflate the balloon. The balloon is going to compress the plaque. So first you thread it in here. It's going to compress the plaque against the wall, forcing the vessel to be open. And then we're going to insert a stent, keeping the vessel open. The stent will also have certain drugs that will elute to keep it patent. Okay, so in stable angina maintenance therapy, you're going to use long-acting nitrovasodilators, or like I said, beta blockers, calcium channel blockers, along with the anticoagulants. So you want to give them low-dose aspirin, like a baby aspirin, or clopidogrel. In hypertensive patients, you only give the beta blocker or the calcium channel blocker. You don't give the low-dose aspirin. Why do we do that? Because we don't want the blood to be too thin. It can cause a hemorrhagic stroke. You use the nitrovasodilators in normal tensive patients, and in variant angina, you give nitrates along with calcium channel blockers, along with the low-dose aspirin or clopidogrel, but you don't give the beta blocker, because remember, beta blocker is going to act on the receptors for the adrenal hormones, and that's not going to work very well with the variant angina. It's not going to help treat anything because the variant angina is also could be due to like variant reentry. So in these patients, bypass and angioplasty is not recommended. We only want to keep them on these medications. Unstable angina or acute coronary syndrome or crescendo angina, this is the most dangerous, so we want to give them medication IV because these patients are definitely not going home. They are staying in the hospital. You give them IV anticoagulant, heparin, along with some other thrombolytic agent. So to really treat, you have to do a surgical procedure. The use of calcium channel blockers and nitrites and beta blockers with low-dose aspirin or clopidogrel and hypolipidemic drug for the prophylaxis. Okay, so coronary steal phenomenon is when this drug, dipyridamole, will divert the blood to the non-ischemic area. So we do this on purpose for erectile dysfunction. We want to divert the blood to the penis. So we use the PDE5 inhibitors, sildenafil, tadalafil, valdanafil, and alprostadil, which is a PDE1 analog, unlike this. Cilostazole, pentosyphiline are going to be used to treat the peripheral vascular disease. This is a PDE3 inhibitor, and it works as a vasodilator. Pentosyphiline is a xanthine derivative, and that thins the blood. Okay, so the next part of this is going to be hematopoietic agents and growth factors. So this is to increase the clotting. They are iron, of course, vitamin B12, and folic acid. Iron is going to be given for iron deficiency anemia, along with the treatment and prophylaxis of this condition. It's going to be contraindicated in hemolytic anemia because the hemolytic anemia is already releasing a lot of free iron. Giving iron on top of iron is going to cause iron toxicity. Vitamin B12 is going to be used to treat the megablastic anemia. So you give the cyanocobalamin, hydroxycobalamin, and methylcobalamin. Have to give it with folic acid because one deficiency is usually accompanied by a B9 deficiency. There's no just like B12 deficiency by itself. In pernicious anemia, vitamin B12 isn't the problem, it's the intrinsic factor. So you have to give both the vitamin B12 and the intrinsic factor. Folinic acid is going to be given for methotrexate toxicity. We'll go through that a lot more later. And folic acid is never given alone because of the neurotoxicity. You have to give it with vitamin B12. So in a histological slide, the megablastic anemia is when the neutrophil is like gigantic, and there are many, many, many lobes of the nucleus. In a neutrophil, there's about like 2 to 3 lobes max. So this is too many lobes. So erythropoietin is a hormone secreted by the kidneys. It's the juxtaglomerular cells that you make the erythropoietin, and that is going to be used to stimulate red blood cell synthesis. Okay, so this is a bit of an aside, but it doesn't just stimulate the synthesis. Well, it doesn't stimulate it like a growth factor. Erythropoietin is actually an apoptotic inhibitor. So the hormone allows these cells to continue living after they've differentiated from the myeloid precursor. It allows the cell to continue differentiating and maturing, even though the red blood cell loses its nucleus. In general, when a cell loses its nucleus, it's time to die. So other cells will undergo apoptosis because this is not normal. Erythropoietin targets the red blood cell precursors and say, no, we want these to continue. So, of course, a problem with like erythropoietin is going to cause aplastic anemia because there's something wrong with the bone marrow. Red blood cells aren't going to mature. Sorry, that was a bit of an aside, but an interesting aside. you want to use recombinant human erythropoietin, so epoetin A or B, and that treats the anemia caused to the renal causes. Only the renal causes, remember. Myeloid growth factor is going to be used to prevent the infection. Granulocyte colony stimulating factors, filgrastim and pegfilgrastim. There are the granulocyte macrophage colony stimulating factors. That's sargramostim, molgramostim, and regramostim. So macrophage stimulator, MOSTIM, granulocyte grastim. So these are helpful hints to help you remember like what drugs are which. So these are used to treat neutropenia. Of course, we want more granulocytes and macrophages, and chemo-induced neutropenia. Megakaryocyte growth factors is going to be used to prevent bleeding because megakaryocytes are the precursor to platelets. Oprelvicin is a recombinant form of interleukin 11, and that's used to treat idiopathic thrombocytopenia for the prevention of chemotherapy-induced thrombocytopenia. So interleukin 11 is going to stimulate the growth of platelets. That's it for now. Thank you for your attention, and good luck studying.